Can you hear us? Deriz, can you hear us?
Yes, we can see you and we can hear you.
We can't hear you yet.
Can you hear me now?
If you get closer to the microphone, because I don't think they can adjust the volume.
I'm also almost chewing the microphone.
Oh, you might have to swallow the microphone then. Okay. All right. At the moment, what can you see? Presumably you see myself and Nazmi?
No, we now see the case.
Okay. Well, who's going to present the case? Do we know?
Yes, I'm presenting.
Okay.
This case is a 5-year-old female, 17 kilogram in body weight. She was asymptomatic, referred to our clinic for evaluation of systolic murmur. On physical examination, there was systolic murmur at upper left sternal border. ECG showed sinus rhythm with right bundle branch block. Transthoracic echocardiography revealed multifenestrated atrial septal aneurysm. The diameter of the largest defect is 11 millimeter, and 2 small additional defects noticed close to the largest one. With color flow, the diameter of the largest one is 14 millimeter. Right heart structures was enlarged. Total septum was measured 35 millimeter, and the IVC rim was floppy. These are transthoracic images. And now on the cath lab, transesophageal echocardiography was performed. The intended intervention was the transcatheter closure of the ASD.
Okay. So what can you see at the moment then? You've got the details from the slides.
We still see the slide.
Okay. Are we able to show you the TOE at the moment? Can we show the echo? So do you see the TOE?
Yes, we see the TOE.
Okay. It's not real time because this was recorded a little bit earlier, but what we see at the moment is let's one view at a time, yeah? So that is a bicaval, almost a bicaval view showing at least 2 defects with an aneurysm of the atrial septum. Go to the next one. The opening or the mouth of the aneurysm is around 14, 15 millimeters on this view. Next. And then you can see a couple of defects there at least. Next. On this view, there's probably 3 defects within that aneurysm. One towards the aorta is a very small one, and then a little bigger further posteriorly, and then the biggest one is further back. Okay, next. Next. Yep, play that. Okay, and that gives you a good view of the atrial septal aneurysm. Next. That's the atrial septal length measurement, which is at least 3 centimeters. It may be more. Yeah, next. Now, do you want to show the 3D of the defect? So this is there another view? That's a 3D of the defect, which shows a multifenestrated defect with a drop. There's a small one where the cursor or arrow is, and then the bigger one there where the arrow is. Okay, so the challenge here was, if we can show the fluoro, is crossing the defect. And in the normal method, can you see the fluoro now?
Yes, we can.
Okay, so in the normal method, crossing with a multi-purpose catheter, and then we thought from the TOE that we were through the main defect, but I thought the best thing was to put a sizing balloon in, not for the purpose of sizing, but really to tell us which defect we're through, because we can easily be misled into thinking we're through the main defect, deliver a device, and then it doesn't configure. So the first balloon here shows a very tight constriction, and that convinced us or confirmed that we were through a smaller defect. Then if we show the next one. Next. Then we're just showing that as the wire goes backwards and forwards through the small defect. Here we thought we were through the second defect or the bigger one, but when we inflated the balloon, it's still through the smaller one. Next. So the next thing we did, rather than keep going across with a multi-purpose catheter, was tried with a pigtail, because if the pigtail crosses without indentation, then it has to go through the larger defect. Next. Next. Yeah. And here we then inflated the balloon through the main defect. And if we now flick to TOE, okay, so there you see the echo, and then once we're through the main defect, the waist on the balloon is around 14, 15, to some extent 16 millimeters. Next, there was a color after that with the balloon inflated, and you can show or see a little residual flow through a couple of small defects. Okay, so if we now go live fluoro, oh, no, that's fine. So any suggestions from you as to what we should do and what device and what size? The balloon size, the balloon waist is around 15, 16 millimeters. Remember, there's an atrial septal aneurysm, which has got an opening of around 2 centimeters, and there are a couple of other defects, small ones. Any suggestions?
Any suggestions?
Flush syringe.
18 or 20? And which device?
You can use
What's that?
normal ASD device, I would put this case. Not
18 you're suggesting, yes, okay.
Yeah.
Any other suggestions?
Cribriform.
Cribriform. Now, we thought about or discussed that. Now, why would you use, what size cribriform would you use?
I also second the cribriform in the smaller defect.
30 millimeters cribriform device.
Which size?
30 millimeter.
30 millimeter. Now, the
Just
problem,
a minute, Carminati has a comment.
yeah, cribriform would be reasonable, but remember the biggest defect here is 15 millimeters, so it just allows the device to perhaps move up and down in the defect and then slip into the aneurysm a little bit as well. So I wasn't...
Shak, may I make a comment on this? When you have multi-perforated defects, the issue is that if you think that there are multiple holes or just a big hole and small additional fenestration, I think you demonstrated enough that there is indeed a big hole with additional fenestration. And if you think about to close this hole with for example, 18, you measure 16, something like this.
15, 16.
Yeah. If you use, for example, an 18 with a double disc device like the Amplatzer, actually the left disc is likely to cover the entire length of the septum, so it's likely to cover the additional holes as well.
Yeah, yeah. Okay, so it sounds like 18 from your end, does it?
Yes.
Yeah. Well, we were thinking of 17, but 1 millimeter is neither here nor there. So
exactly.
At the moment, we've got if we show you live fluoro, that's a 9 French torque view sheath in the left upper pulmonary vein. If we very quickly show the echo, and you can see very nicely 3D echo with a sheath across the main defect. So we will use, as you suggest, an 18 millimeter Amplatzer device. So with me here, I don't know if you can see us, but there's myself, not surprisingly, and then Dr. Nazmi is the first operator. Can you show Dr. Nazmi? They don't need to see me. Okay, there you go. And Shakeel on my right. Okay, so now we need a device, I think. 18, and a bowl or something with, is that saline? So we close up, just to convince you that it says 18 on the, yep, there you go. That's 18 millimeter Amplatzer septal occluder. And here it is. Here's the device for those of you close up, those of you who haven't used it. So left atrial disc on there, right atrial disc here, and then a screw mechanism here. Right, so this is a good test of the eyesight. So we attach the device when I can see it. So we attach it really tight and then a little unclicking so that the device is not too tight. And then we load the device.
There is a comment from the audience.
Pardon?
There is a comment from the audience.
A what?
They measured the total septum
Comment.
30 millimeter, right?
All right, so then the device is being loaded
36.
into the loader
Total
and
septum.
now
It's
being
a good
flushed.
option.
Yeah, flush more. Yeah, okay, that's fine. And then Dr. Nazmi is going to introduce the device. We need a flush. Okay. Okay, so that's the device going in, and then Nazmi, if you show the fluoro in a second. And then in a minute, if we can show echo and fluoro superimposed. Yeah, you've got echo fluoro. Okay, so go ahead. Do you want AP or LAO? You're okay. All right, so we need TOE guidance to show us. Okay. Right, so that's the left atrial disc delivered, and now we need some echo help to tell us where we are. Okay, Nazmi. Very slowly, okay. All right, stay on the 2D now, and then shows the left atrial disc. Yep, and stay on that view, but yeah, hold on. Let's just get the view sorted out. Okay, that's fine. Are we all right on the echo? This is all a bit squashed. So just fluoro for a sec. Nazmi, fluoro. And no, I would go in a little bit more in the left atrium so that we capture the aneurysm mouth. So push a bit more. Yeah. Okay, so rather than pull the device in, I would deliver the waist and then pull it, yeah? So, no, I would deliver the waist a little bit. Okay, now just hold that and tell us on the TOE. Yeah, okay. And then if you keep that and then pull the sheath back, yeah? And now push ahead, yeah? All right, the right atrial disc, if you cine that, the right atrial disc is delivered. Now if we can have a look on TOE to make sure we're on either side of the septum. Can you do a cine? Cine. Okay, so have a look with color as well as 2D. Yeah. Right, just to push everything. That's better. Yeah, that's it. So can you see echo and fluoro? Echo, yeah, that looks as if we've captured the atrial septal aneurysm, as well as there's a little bit of flow through the discs or between the discs. Can you look at different views, 120 as well?
What do you think about the size, Shaq? Do you think it's
I think it's slightly oversized, isn't it?
Yeah.
Probably it'll reconfigure itself, but 16 or 17 is what I was thinking before, but you know, I think that looks good.
Could you maybe comment, Shaq, in these fenestrated ASDs, the risk of, for example, if you size it, that you may rupture a tissue bridge in these fenestrated defects? Have you ever encountered, for example, placing your device and then the next day it embolized because one of the tissue bridges ruptured?
Yeah, the thing about atrial septal aneurysms is that you probably need to get the positioning right at the first attempt, because if you have to, and that means you have to be through the correct defect, because if you have to keep retrieving the device, then you're likely to tear the atrial septum, and then either the device may not stick or you'll have to resize it, and so on. So that is one of the risks. So you have to get it right at the first attempt. Okay, so I think it's a little oversized, but I'm comfortable with that, a little oversizing of 18 millimeters. So if we just, I'm not going to do any tugging or anything, if that's all right with you.
It's fine with us.
And then we'll release it. So if we do a cine. Okay.
So, in the audience, the audience doesn't agree. Can we have a microphone?
Sure.
There's somebody in the audience that wants to make a comment. Check.
Hi, Shaq and Nazmi.
Yeah.
Did you already release? There is nothing to put.
So, but what was your concern anyway? No? Yeah. What is your concern? Use the microphone.
I can't hear.
For me, I will not release this device. This is oversized. If we are lucky, it will tear the septum late tomorrow, and all the discs will come together. In this way, look at the device. It's too much. When we go to the about 70 or the 80 degree lateral, we can see the internal waist. We can measure it. I think it will be maximum 15, but we put 18 device. So it's oversized. It's not a good thing to put. We have chance to go there. It's a good patient for the manipulation. We have aortic rim, no problem. We can put smaller device and check it. If we are happy, we can release. For me, I was trying first. This is not 18. It's not a good choice, but they have already opened the device.
So we didn't really catch a lot of that, other than concern about I would not release the device. What was the suggestion to use what?
Shaq, it's Joe here. I think the suggestion was that this was too big a device, and therefore a 16 would have been better.
Yes.
And I think if I were to, do this case, I would go for a 16 because there was waste on the balloon.
Yes.
But I don't think this is too big or is going to cause problems. The point that the Rees made about the tissue tear, I think is very relevant if you put two devices, but less so, I think, when you put one device.
Okay. So on the echo that you've seen, it looks, it's 1 millimeter is neither here nor there.
There's one more question from the audience.
Yeah, the point I was going to make was that on color, there's very little flow. We seem to have covered the other little holes. There's a little bit of flow through well, not even that now, or between the two discs, and that will eventually go. So go ahead with your question.
Yeah, Shaq Mansour. Just a question. If you use a cribriform device in this patient, probably it will have a better profile. Probably will have the right disc and left disc will come approach each other in a better way, and probably you don't need to bother to come through the larger defect as far as you are central within the atrial septum.
Yeah. Well, that's a very good suggestion. We discussed about the cribriform device here as well. On balance, I thought because it was a 14, 15 millimeter defect, the cribriform waist itself is very small, and so the device is likely to pop into the aneurysm and then miss one of the other defects. And so we thought we'll go for a simple option, which is the Amplatzer septal occluder. But this defect can be closed with multiple different types of devices. That's not a problem. But we seem to have got a good result.
There's still one more comment from the audience, 2 comments, and then I think we'll...
Since the patient has aneurysmatic septum...
Can you speak a little bit louder into the microphone because I can't hear you?
Since the patient has aneurysmatic septum, could it be a better selection of instead of regular device, LifeTech or Occlutech, before releasing the device, we could see easily the position of device safely? What do you think about this?
Right. Can you say that again with a better microphone? What was the question or comment?
The question was, or the comment was that if you would use another device because of the aneurysm, an Occlutech, LifeTech device or Occlutech.
Okay, so
but it's the same.
If I understood it correctly, the reason why not use other devices? So you would have a choice of Occlutech, and Occlutech has a very similar waist if you're using the regular atrial septal defect.
We are talking about the flex system.
Yeah, the flex system is still, the discs are the same. It's just a flex allowing you angulation. The same happens with the Seraflex. It's got a little bit better angulation, but the discs, the shapes and everything else are fairly similar. So that necessarily does not, you can use, as I said before, any of those devices could be used.
Good. Last comment from the audience. Can we have a microphone, please?
Okay.
Sorry.
Shak.
Yeah.
Sorry. No, the question was actually, just to tell you the question. The question was to use a device that before release, it will have no too much movement after release, such as Occlutech or, the new BFM, where you release and then there is still attached, or Helix device that still will be attached in a thread so you can see it before complete. I have just a comment. When you have this kind of multifenestrated, like what you did, Shak, you went in 2-3 times, it is maybe good to have a balloon and keep the balloon inflated, use the other groin and try to cross the holy one. That's make it easy. The worst thing is that you have to put another axis.
Yeah, I think the balloon in this particular type of morphology has an important role, partly to size it, but more importantly to cross the main or the correct defect. Okay,
after releasing, please measure the internal waist diameter of the device. Now, from echo, and I always do it after releasing, I put the angio to the almost 80 or 90 left anterior oblique or lateral view. You can easily see the waist of the device, then measure it. But then I say, oh, I had to put this device, or you will please measure the internal waist of the device.
Can you measure the waist
with
for
echo? Look.
Levant, I agree with you. I tend to measure the waist, but the problem arises in terms of imaging, getting the waist on echo as well as fluoro, calibration and so on. So, yeah, but it's not the best. It's not the best image. You can't see.
Fluoro is better, Shak. Please turn to the 80 or 90 left oblique. You will see very good waist, and you can measure that. I generally use the sizing balloon, putting in the front of the patient, then measuring, and I'm checking if I did if I put a correct device or not.
On the fluoro, LAO 70, let's see. All right. We will do the measurements, but you're probably way behind the program. So, do you want to carry on with lectures, or are you going for lunch?
Okay, Shak, you measure it and tell Dr. Levant at lunchtime.
Okay.
Because
absolutely, we'll let you know.
Thank you very much.
Okay, thank you.
I think we will break for